Yes, I worked full time as an LPN in undergrad. I like took night classes when I had to take night classes, or worked overnight and went to school in the daytime. Um,
Hi, everybody. Hello. Hi, guys. Welcome to ep24. I'm Rodalyn. I'm the host for ep24. And tonight we have Bookie as our guest. She is an internal medicine and emergency medicine PA. Thank you so much, Bookie, for coming on tonight.
Hi, Rodalyn. Thank you for having me. I'm like happy to be here.
Thank you so much. This is awesome. So you guys, Bookie, as I said, is in internal medicine and emergency medicine as well. So we're gonna first start off by finding out or learning more about her and her PA journey. So can you tell us more about how why you chose PA, what you did to become a PA, and tell us more about yourself, Bookie?
Okay, so I chose PA because when I was in high school, my journey is very similar to Rodland. Like, you did LPN in high school.
Yeah.
I did LPN in high school too, and I actually found out about PA, like the profession, during my senior year in high school. So when I was doing rotations, I met like a PA in. She was doing surgery. She was in like um cardiac surgery, I think. I remember, and she was doing like a femoral artery bypass or whatever, and I was like, oh my god, like, you're amazing, I want to like be you when I grow up. So that was how I found out about the career, and then I did a huge research, and I decided I was going to go to undergrad, get like 2 years first, and then transfer into like a bachelor's program for PA.
Okay.
But then by the time I was 2 years into college already, a lot of the programs started switching to a master's program. And stopped really accepting students with just like the 2 years undergrad and then like the complete 2 years of bachelor's. So I figured I'm going to finish bachelor's program, get a degree, and then apply for master's, and which is what I did.
Okay, awesome. So, how long did it take you to, get through all that? So, you work during college as the LPN and got your hours?
Yes. I worked full time as an LPN in undergrad. I like took night classes when I had to take night classes, or worked overnight and went to school in the daytime. I switched degrees a couple, like twice. I was first pre-med, like by general bio, like everyone else goes into. Yeah. But then I realized that like I wasn't really, like, I love healthcare, but I don't really care for the like, I guess, biological science part of it, if that makes sense. Like, I'm not really into research, things like that. I'm more into like providing care. And so I figured, why get a bio degree? So I switched to English because I love writing, I love reading. Yeah. I love being creative. So I I finished with a bachelor's in English in a little over 4 years, plus my prerequisites for PA school. And then I applied to PA school during my senior year of college.
Okay, awesome. That's really awesome. And you guys, like, as she did, you do not need a science background or science degree to go to PA school. She got her degree. It was non-science degree. It's in English, right?
Yes, English, creative writing, actually.
And that's awesome. And I bet that made you come off as more well-rounded rather than just, full biology background.
I think it definitely helped me in my application process, because a lot of people they want to be straight A students. They want to be science. They want to have everything. And I kind of was like, I was not a straight A student. I had a couple of B's. I had 1 or 2 C's. And I also had a lot of like art classes that I think balanced me out in terms of, I was an LPN. I had like healthcare experience. My science was pretty strong, not the strongest. And I think I conveyed a lot of like why I wanted to be a PA in a creative way in my essay. And I think those were some of the things that helped me get like the interviews and a little bit of step ahead during my application process.
Awesome. So did you have to take a gap year?
No, not really. So when I went to, I started undergrad in 2012, fall of 2012. Then I was supposed to graduate in 2016, but because I was still taking prereqs plus finishing up English degree, it kind of took a little bit longer than the traditional 4 years. So I technically finished one extra semester than the usual 4 years.
Okay.
And then I started applying during that, like my senior year, the end of senior year, and which was like in the summertime.
Yeah.
And then I interviewed through the fall when I was finishing up my degree. And then I started school the next spring.
Okay.
So technically I didn't really have a gap year. Yeah, I didn't really have a gap year.
Okay, you just had like
I got lucky.
That's awesome.
I hate to say it, but I really got lucky with like my acceptance into PA school. Like,
yeah,
it was one of those last minute stories of like, yay.
That's awesome. That's awesome. And if you don't mind sharing, how many schools did you apply to? What was the application process like, and interviewing, and what, like, do you remember any questions that they asked you that stood out, and what advice can you give to students, especially now that applications or CASPA is going to be opening, and then interview season is starting up or upon us? So what advice can you give students as they go through that process?
So you asked a lot of questions. Okay. I'm trying to.
I know it was a lot. It was like one question with multiple other questions. But basically, what advice do you give students during the application?
Okay. So I'm gonna try and answer as much as I remember. Okay. So I think I applied to about 8 to 9 schools. I was short on money. I worked through school, so no one, like, applications are very expensive. And I was also applying with not finishing up my degree yet. So I had, like, I think statistics outstanding, and I was still racking up shadowing hours. Healthcare experience wasn't an issue for me because as an LPN, I already have years of working. So I used those as my healthcare experience. So in that area, it wasn't an issue for me. Right. The schools that I applied to was also a little harder for me because I didn't take a GRE. I was still in school. I was working full time. I knew studying for the GRE and taking it would not be my best interest. So I made a decision at the time not to actually take the GRE and apply to schools that did not need GRE or biochemistry, because I didn't have enough time to take biochem at the time. So I opted not. Actually, I'm lying. I did take biochem, and then I dropped it when I realized I was not going to be able to pass the class. So I dropped it within like a month of starting the class. I was like, there's no way I can do this and have a decent application. So I dropped biochem immediately. And then I dropped biochem. I didn't take the GRE. So that limited a lot of the schools I could apply to. I only applied to schools that did not need GRE or biochemistry. And I try to make my application strong with my essays, my letters of recommendations. I started getting people to write them early for me and review them more than once, actually. I asked them if it's okay for them to review the letters of recommendations with me, because I worked with a mentorship program in college, and I assisted students with their college with their college applications. So I'm a little bit aware of like what schools are looking for on recommendation letters. Mm-hmm. So I was like, I need you to tweak this. You need to make it a little bit more personal. You need to, highlight certain strengths that I have. It's a little bit cheating, but it helps you get along and get ahead in the best way possible. So then what else did I do? I had 4 interviews. I had 4 interviews. I got rejected from 2. I got waitlisted at 2, and then one of my last waitlisting was with Downstate Medical Center, and they were expanding their class. So I was one of the last 5 students that they took in at the very, very last minute.
What a blessing.
I know.
That's amazing. That's awesome. And is that a 24-month program?
27. It was a 27. Okay. We started in May and then finished up in August.
Okay, mine too. My program was as well. Okay, nice. Okay, so now let's go on to PA school. So you graduated PA school in 2019 or 2020? Well, August 2019, right?
August 2019,
Okay,
I graduated.
Okay, nice. Okay, so can you tell us about PA school, how it was like for you? Any tips and advice for students that are, well, of course, hopefully everybody gets into PA school, but yeah, what can you tell us about PA school?
So for me, I got a weird start. I started a day or two after school started because of the waitlisting issue. By the time they called me and told me they had accepted me, everything, they had like technically the first day and second day of class already start. So I kind of missed the whole orientation part, the whole getting to know my classmate. So I kind of started like I was thrown right in. I didn't get no like one day of like getting to know everybody. But my blessings came from having an LPN background. So a lot of like anatomy, a lot of healthcare words, or like a lot of pharmacology was already something that I kind of knew already. So that helped me a lot. But I found studying for PA school to be very, very challenging. And anyone who goes through it will tell you, you have to adjust your studying habits. When I went to undergrad, I was not the strongest student for studying. I will be very honest. I BS'd my way through. Like, if I had an exam, I'll probably study the day or two before it because I was always working and I had a social life. So, PA school, adjusting to that was tough. Having to now figure out what works for me, what doesn't. Do I write things out or do I listen to lectures? Do I walk and read and reteach myself? And hopefully this sticks. That's kind of how I went about it. And I relied a lot on my friends. So PA school, I relied so much on my classmates. I had a crew. There was 2 other girls. And when I tell you, after class, we would go to the library and we would like hammer down on a specific goal. We're going to get through this part of anatomy today. We're going to get through this part of pathophysiology today. We're going to do pharmacology and like hone in on mechanism of action on this topic. So having a core group or like a clique, I hate to say it, but like a few people that you can really, really work with together and study together, and you guys have a similar studying technique, is very, very helpful because you guys will work together to get through this, the program, and you won't feel alone. And PS2 can be very, very lonely. You can go days without having to see your family members or having social life or be able to just relax and have a downtime. So if you have someone or a couple of people in class that you're able to study with, you will like be able to get so far so fast. And I think those were some of the things that helped me.
Okay, wow.
I hope I'm answering you guys questions because I'm a little nervous.
There's a lot of questions. I tried to go through the chat and see anything. I mean, you've answered quite a few of them already. One question was, when you applied to PA school, was there a distinction between healthcare experience and patient care experience on CASPA?
Yes. So healthcare experience, correct me if I'm wrong, I'm not 100% sure, but healthcare experience it could be, I believe it can include shadowing, it could include like scribe. It's just general term in terms of a broader, like, you're not direct patient care. So patient care would be direct patient care where you're taking back on a patient, you're providing PCA, like personal care to them, you're giving them medications, you're treating them. And I think healthcare experience was more the broader view of like maybe you're just transcribing or like you're like extra tech, you're not providing direct patient care to the patient, if you get what I mean.
Right. And a lot of them wanted to know, you said you went to SUNY Downstate Medical?
Yes, I went to SUNY Downstate in Brooklyn. Okay. Shout out.
Nice.
Best school.
Nice.
Pro-Black, very diverse.
Okay.
Have to put that in real quick.
Nice. So they did not require the GRE?
No, and I believe too now they still don't require GRE.
Okay.
I'm not sure about biochem though. Double check on that. But I know till now they do not require you to have a GRE.
Okay, so anyone in the New York area or that wants to come to New York, you can apply to SUNY downstate. They don't require the GRE. And somebody asked, what any personal statements, advice that you can give for your essay?
Tell us. Everyone tells you this, right? Tell a story.
Yeah.
Don't just don't just blur out like, or why you want to only be a PA. You have to kind of craft a story that is very connected or very special to you. For me, I began my personal statement with my seeing a doctor back home in Nigeria, right? And the difference of healthcare back home as a young girl compared to healthcare here in the United States, and having to go through LPN school and seeing the difference as a nurse, seeing what I hope to aspire as a physician assistant, and how my journey through taking science courses, English courses kind of blends together. I have a heart for creative creative arts. I love to read, I love to write, I take pictures. I love playing with hair. Like, I'm very creative.
Right.
And I think being hands-on, all those part of me also speaks to how I provide healthcare, like how I provide care for my patients too. If I see a patient and their hair was unruly as a nurse, I will help them like adjust it. I help them like fix it. Like, I would read or sit with my patients and like write letters to their family members. Like, things like that are kind of like what I like show them that I'm a full rounded person, right? I love to provide care. I want to give care to these people, but at the same time, I have a part of me that's a little bit outside of the healthcare profession, but they blend together really well. And some of these things are why I would be a really great provider, and you need more people like myself in your program. Like, you gotta sell yourself, make it sound good.
That's what I tell them all the time.
And write your personal statement more than once. Like, I wrote it a couple of times and I redrafted until like someone, and then like I was like, okay, I think I have it now. And I had someone like go over it with me so many times. Yes. So you have to keep working. It's not just a one-time shot. A book is not written in one day. You need several edits, several drafts.
Exactly. That's what I tell them all the time. I'm glad that you said that. Alrighty. So now we're going to go into more about your career. So once you graduated PA school, how hard was it to find a job? And not only that, but maybe did you already have a job like lined up while in school that you got during rotations? Can you tell us about that process?
Yeah. Excuse me. I wanted to go into emergency medicine. If you ask me, as soon as like I was like starting PA class, like ED, you're gonna find me in the ED or surgery, because I love hands-on. But surgery kind of scared me a little bit because as a new grad, they hire a lot of new grads, but I was not sure I wanted to start in surgery. So I was like, ED definitely was where I wanted to go through. If you live in New York City, or if you know New York City, there's a lot of PAs out here. A lot of hospitals don't like hiring new grads in their hospital either, unless like you're doing like a fellowship or something. And I was not ready to leave New York yet. So I had to ask, I let my mentors know, all my faculty know that I'm looking for a PA job in the emergency room as soon as like we finish school. So send out, like, tell your faculty, your mentors, people that are like working already, that like you're looking for a job in a specific field, especially if those people are in those fields, or they may know people or other people in hospitals. Word of the mouth gets you a job way quicker than a resume online. Let me tell you that, okay? And then I sent in applications to all like Mount Sinai, Northwell, all these great hospitals in New York. Nobody was biting. Then one of my faculty members was like, oh, like Downstate is hiring in the ED. Do you want to, apply and see what happens? So I was like, of course. And I went to Downstate. So I was lucky enough to send in my resume, and I met with my supervisor, and the interview process. I did like 2 interviews with them. I met with some of the PAs. I clicked with a lot of the providers in the ED as well. And it's a very small ED. So it wasn't like, it's not a trauma one. It's not a major, like, it's not a big emergency room. So I think for me to start out, it was like perfect job to start out with. So I was one of the lucky ones that, you know, it's just word of the mouth. You tell people you're looking for something and then they refer you.
That's awesome.
But I definitely do think that's one of the best ways to stand out and ask for jobs, especially in New York City. It's hot out here.
Yeah, that's awesome. What about internal medicine?
Oh, so the internal medicine, I just started that in like October, November-ish of 2020. It's a per diem job that I'm doing with one of the hospitals. I just work on the floor with them.
Okay.
And it's not a full-time job. It's just I do it as needed. So 1 or 2 shifts a week I try to do. I don't really claim I am that much because I'm still learning. There's so much to know with internal medicine. And I don't do it all the time for me to really be, I guess, well-versed in it. So I'm probably not the strongest IMPA yet.
No, but that's still great. That's still great that, you know, you were able to get jobs in both sectors so early on. That's awesome.
Yes. I was proactive. Girl, I'm trying to pay off these loans.
I know. Oh, I know. So is SUNY a private school or public?
It's a public school, but unfortunately, when I started, fortunately, we turned into a master's program. Unfortunately, tuition went up the way nobody expected because now we were masters and everyone is now like, PA is a hot cake profession. So they start increasing tuition every semester.
Wow.
Like, come on.
Wow. Okay. So so we're going to focus more on emergency medicine rather than internal medicine since that's your forte.
Yeah.
So can you tell us like about a day in the life in emergency medicine for you from the minute like you walk in and clock in to clock out?
So we come in and I work in fast track. So in my hospital was divided in 3 segments: pediatric, fast track, and main ED. Our fast track is where the PAs are fully staffed, and then once in a while we'll pick up shifts in the main ED.
Okay.
So as soon as I come in, if it's like the 7 a.m. shift, I'll be the first and only PA. And then I start seeing patients if there's any patients to be seen. If there are not, I can go through like the callback logs, which is like follow up for like certain labs that we kind of monitor. Mostly a lot of like if it's CT callbacks that needed like abnormal results. If it's abnormal like HIV testing, things like that, we'll do like quick callbacks for that and start seeing patients. And you see patients all day.
Yeah,
and then I go home.
It's like nonstop.
Non-freaking stop.
Yeah.
Oh my God.
So you work day shift?
So yes. No, my ED is rotating. So the PAs get to rotate. So you have rotating schedules like day, afternoon, evening, and nights, as well as weekends. I actually just switched to full nights this weekend. So this weekend, and going forward, I'm gonna be full time, all nights only.
I'm sorry. I mean, I like nights though. Like that's basically what I've worked like my whole life, night shift. I'm a night owl. A lot of people don't like nights, but I enjoy it.
So I like prior to starting PA, like the PA nights. As an LPN, I did nights too, and I actually like nights. But for me, like the rotating was just killing me.
Yeah.
Like days to nights. That's how I was like when I had the opportunity to switch to full nights. I was like, can I just switch to full nights? I just need stability, and having the stability to just come in 7 to 7 every night whenever I have a shift sounds and is way better for me and my sleeping pattern.
Exactly.
So I just need enough that's just able. And yeah, nights in the ED is actually not that bad.
Yeah, it's not for the most part.
I see a lot of autonomy too.
Yeah.
So, and I like
Yeah, because I'm not with the whole rotating. They try to do that back in Atlanta, and then I'm like, let me just go full nights, because initially I was like days, and then they started doing that rotating evening and nights because they needed more nighttime coverage. So I was just like, no, I'm gonna just stick to nights, because I hate rotating. I hate one day days and the next day nights. No,
it's hard. Like I'll have a 7 a.m. to 7 p.m. shift. Then the next day an 11 a.m. to 11, or like 11 a.m. to 11 p.m. Then I gotta be back at 7 a.m. I'll be like, yo, my body can't get used to this.
Yeah. So they're 12-hour shifts. They're all 12 hours.
Yeah, we're 12-hour shifts. There's some PAs that do 8 hours or 10 hours for the nights. Our hospital is one of the best. We have one of the best staff and supervisors. They allow you to cut down, if you don't want to do 12-hour overnights, they allow you to cut it down to like 8 hours. Okay. And then you just make up the 4 hours on the day shift another day. Okay. So, nice. But I do only 3/12. I can't be coming back and forth more days.
So you just work 3 days a week? Typically.
Yes, my 3/12s. I meant just 3/12s and 12 shifts a month.
Awesome. Yeah, I told you guys that one of these days, like last week or the week before, about the ED schedule. It's really good. Is you work like 12 to 14 shifts a month, depending on whether it's like 10 or 12 hours. Yeah, that's awesome. And you still get like a pretty decent, really good pay.
Yes.
Alrighty.
Yes. All right.
So let me see any questions that they may have before we go on to the case study. Did you feel like you were prepared when you started working as a PA, or did you take some time to adjust and feel confident in your skills?
It took me a little bit of time. So I started when COVID just hit. COVID hit March. Yeah. Like first week of March, and then by second week things were shutting down in New York. For me, I started March 5th, and that was when COVID just hit New York City. So basically, I started knowing only how to treat cases COVID related, like really rapid cases and patients and stuff. So to start out like that was not what I was expecting. I was kind of expecting to be a little bit babied, and but like no one had time to baby you. You had like 4-hour waiting times in the ED. So I had to like run through the trenches and do what I had to do. But I'm so lucky I work in a teaching hospital, and I have a lot of support. All the attendants, my fellow PAs, the nurses, everybody was willing to help, assist me. If I had any questions, they were willing to assist. And that's one advice I would definitely tell anybody, is that like, I know sometimes working in the ED or working in the teaching hospital can be, it has its drawbacks, but I think it has a lot of positives for any new graduate that is trying to get comfortable, trying to learn, and trying to know a lot as soon as they start. So working in a teaching hospital for me, at least in New York City, has been one of the best things ever, because I have a lot of support. Like if I had questions or anything, someone was willing to help me. I had an attendant that I can pull, like, oh, I need this. Can you look this over? Or like, I'm not sure of this. Can you do this? Can you assist me? And I have a lot of autonomy, but I also have a lot of support, which is one of the reasons why the PA profession is amazing.
Yes. And how is your work-life balance?
Oh, girl, it could be better. I'm not gonna lie. Okay, so we all say we want to go into PA and have this crazy work-life balance. I will probably have a better work-life balance if I didn't have a full-time job, a per diem job, and trying to hustle and pay off my loans as possible. So right now, my goal in my life right now is to pay off my loans ASAP. When I mean ASAP, like as if yesterday, okay? So I am working a lot. It's now allowing me to have a lot of personal time, but I still get to take personal times. Like I get at least 1 or 2 days in a week that I just stay home. I got my hair done today.
Nice.
Like I could travel. If COVID wasn't crazy, I'm sure like I'd be able to travel more. But like there is ability to have a good work-life balance, but I personally just haven't really had that opportunity because I'm working a lot more, but I'm choosing to work a lot more because I have a goal. So it's definitely possible for you to have I have friends. She works Monday through Friday, 8 to 4, surgery PA. And when I tell you sis is out almost every other day, she travels. I have a friend who's doing IM, and she works like 3 shifts a week, but then sometimes she'll stack it together so she can get like a whole week off in the month without having to take vacation time off. And so there is ability to have a good work-life balance. Trust me. I just personally, I've just been working like crazy because I have a goal.
No, so. That's awesome. Girl, same here. I work like a dog. Same here. I actually have to go in after this. But
Woo, girl.
So,
I understand.
Thank you so much for answering the question. So we're going to move on to the case study. Okay. Do you have a presentation or you want to walk through it?
I do have a presentation. Can I share screen or do I need to send it to you?
No, you can share screen, or if you go, there's a tab that says add new presentation. It's like a projector tab. Do you see that? And you can like upload your presentation, or you can share the screen, whatever you like.
Yeah, let me see if I can just share the screen. That might be better.
Okay. And they wanted to know about your social media, if you could share, if it's okay to contact you or reach out to you.
Yes, you guys can reach out to me on my social media or email. Okay. I promise I think I'm pretty decent with responding at a decent time, but if I'm not able to, trust me, I will eventually get to everyone.
Okay, I put her social in the comment section, guys. Her Instagram. Sorry. And then, you guys know for case studies, we have a student. We allow a student to come on and go through the case studies together with us. So if you're interested, just raise your hand. I'm trying to put in her email. Hold on. I am on my phone, so it's okay. I'll put it in later. Okay, here we go. Anybody? Let's see. Okay, so it looks like Stephanie raised her hand for the case study. Okay, here we go.
Can you guys still see me, or it's just the screen only?
I see you. It's like a little pick at the bottom.
Oh, okay.
Okay. So, Stephanie.
Oh my gosh, I'm on. I'm so excited. Wait, can you see me?
Hi.
Can you see me?
Oh, I can see you.
Okay, oh my gosh. I don't even know what to do with myself. Okay. Okay, hi.
How are you?
Good, and you?
I'm great. I hope the session has been helpful, and I just want to say, I hope you guys love what Rattling has been doing. This platform is amazing.
Thank you. All righty. So, Stephanie, Buki's gonna present her case study. So you're just gonna basically, Buki, walk her through the case study. You can ask her questions as it relates to the case, whatever the case study is about. Ask. Well, I'll let you guys walk through it. I'm sure she'll have interest, and she has an interesting case study. So it's for fun and learning, of course.
Can I say something?
Yeah.
Yes.
I was like, this girl has to be African. Like, she has to be African. And I'm Ghanaian, by the
way. Are you Nigerian too, Stephanie?
Well, I'm like 25% Nigerian, but I'm Ghanaian.
I take you. I will claim
you.
Okay. Awesome.
All right. So should I make it like the full screen?
Yeah, you can make it full screen. Oh, that's perfect. Okay. That's perfect.
That's better?
Yeah.
All right. Hi, everyone. So as I said, I work in the emergency room. This is just a quick overview. I kind of broke it down into what fast track and main ED. As I said previously, my hospital has the main emergency room. And now main ED, we see patients like urgent to resuscitation, which is like if you need transfusion, sepsis, stroke patients with like chronic multiple comorbidities like renal transplant, cardiac transplants, like those kind of complex cases. And then our fast track doesn't only see what the traditional fast track in other like big hospitals is, which is just like musculoskeletal, quick, like 30-minute things. But like we will see patients who come in with headaches, possible like strokes as well. But like if they're not like, if you think they have like loss of consciousness, but like possibly not a brain bleed or whatever, then we will see them in fast track too. We will see patients with abdominal pain that needs to be admitted or possibly go into surgery. We will also see them in fast track. So fast track is has a little bit more of what other hospitals call main ED. So we kind of see a little bit of both. It's kind of weird, but it works. It allows me to see a lot of the things that I would not see in other hospitals fast track. Do you guys get what I mean?
Yeah.
Okay. So the next thing is, so I had a patient just like last week or 2 weeks ago. She came in for abdominal pain for 6 months. What would you initially start thinking when a patient tells you I have an abdominal pain for 6 months?
Okay. Automatically I would start thinking like, is this cramp related? Is this menstrual pains? Is this gastritis or something? Like, is this, something like, I guess like something obviously like related to the stomach, like, that's what I would start thinking. I would start to limit down those like, cramps and stuff.
Great. That's amazing. Okay. So, she did come in. She said she's been having abdominal pain for 6 months, right? Mm-hmm. And then, in terms of, I'm not sure if you guys are aware of like how to ask questions, how to do your HPI. So I usually, in PA school, they teach you a lot of different tricks and mnemonics to remember. And old cards is my favorite one in terms for HPIs, right? So O would be for onset, how long, and when did they start? 6 months ago. Mm-hmm. She said it was localized to her right lower quadrant. It comes and go intermittently. And she describes it as crampy pain and sometimes shooting pain. And it's worse when she moves, and it gets a little better when she takes ibuprofen. Okay. And it radiates to her pelvis as well as lower back. And she gets this every day. But for the last 3 days, the pain got worse. And she will rate it at its worst 9 out of 10. So now, from this type of quick mini history, what else would you start thinking about?
Okay. I will start thinking about like pregnancy. I will start to I'm a little nervous, so like I'm not really sure.
It's all right. No, you're on the right track. So you're right. Like you would think of pregnancy, right? If you're thinking of pregnancies, what are you thinking? Like ectopic, right? Yeah. Like it could be something, it's just saying shooting crampy pain, right? And it got worse in the last 3 days. So patients will come in and tell you they have this chronic pain of back pain that's been going on for years. And then you ask them, okay, so why did you come into the ED today? Oh, I fell yesterday. All right. So not only have you had this chronic pain, but it got worse yesterday, or something happened that triggered it, that made it worse, and which is why you're here.
Maybe fibroids. Maybe a fibroid.
Ooh, amazing. Okay. Yep. There you go. There you go. All right. So I'm not sure if I'm doing this the way Riley wants me to do it, but I hope.
No, you are. You are. You're doing great.
Okay. All right.
I love it. That's why I haven't said anything. I'm like, you're doing great.
All right. So she said it got worse in the last 3 days, and she told me she knew that perfectly this pain was different than her usual pain. So even though patients write one thing on their card or they tell you one thing initially, getting to the bottom or like asking them more in-depth questions and then trying to get them to tell you what they can't tell you initially is kind of where your work as a PA is very, very important. History is one of the main things that you can do as a provider to help your patient, because a really good history sets the tone for how and what type of treatment and how quick a patient can be treated in the emergency room. Okay? All right. So her medical history, she has a history of bicornuate uterus and ovarian cyst. She denies any surgeries in the past, and her only family history is hypertension and diabetes, and she doesn't take any medication. All right? So now, like, I'm not going to lie to you. When this patient was telling me all of this, I had my mindset on, ooh, I think I know what this is. I already started, like, putting my top differential things that could kill her to things that, is just regular, like, okay, this could possibly be it, but not likely. All right. So let me tell you some of the things I started thinking about when I saw when she took her medical history. I was like, okay, so she could possibly have a cyst, right? That has ruptured, correct,
Mhm.
right? She could possibly have a torsion because if you're having shooting pain that got worse in the last 3 days and it's not going away and it's a little different from her usual belly pain and it's radiating to the pelvis, you start thinking pelvic organs, correct? So those were some of the things that I started thinking about immediately. Then I'm not sure, am I doing this correctly? Yeah, okay. So these are her reviews of system. She denied anorexia. She was like, she didn't have any fever or weight loss. She didn't have any chest pain or palpitation. The only thing pertinent was the abdominal pain. She denies any nausea, vomiting, and diarrhea, but she does have the low back pain. No dizziness, no loss of consciousness. If a patient tells you all of this, I'm not sure how well, like, do you know anything about like healthcare in terms of exams that you do during physical exam, Stephanie?
No, I don't really know the specific names.
Okay. So there are different exams that you do. Like during school, they teach you special tests, right? You know, when you listen to the lungs, there's special tests you do to rule out pneumonia. There's special tests you do for different things like abdominal pain. If you want to do like a quick Murphy exam to rule out gallbladder stone or some like infection of the gallbladder, you could do the Murphy sign. If you want to do appendicitis, you do like the Rolfson sign or the obturator sign or the psoas sign. There's like special tests in each section of the system that we do. And one of the ones that I did for her was the obturator sign and the psoas sign because I was like, okay, I wanted to quickly rule out if she had like an appendicitis because she's saying the right lower quadrant, correct? I'm sorry, I keep saying correct. Let's see if you guys can't hear me. Don't mind me. All right, so her physical exam, she looked really well. She was not in any distress. This woman looked like she looked amazing, in my opinion, for a woman who's like right lower quadrant pain is not getting better. Her vitals were normal. Oh, I didn't write them here, but she didn't like have any temp. She did not have any. She was not tacky. She did not have, her pressure was within normal limits that day. The pertinent history that I got from her was she was very tender to the right lower quadrant and suprapubic area. Her belly was soft. I could hear her bowel sounds, and I did a pelvic exam. On a pelvic exam, I just saw only vaginal discharge, like a normal vaginal discharge, which is like clearish, whitish discharge. There was no cervical motion tenderness. So cervical motion tenderness is when you put two fingers in the vaginal vault, and then you kind of rotate or swing the cervix a little bit. And most patients will be tender if they have certain things like PI, pelvic inflammatory disease, if they have any inflammation going on, any tubal ovarian abscess, like a rupture thing, like sometimes they will have they will most likely have some tenderness. They'll be very, very uncomfortable. And then you put those two fingers, you rotate it to the left side to check for the adnexals, which are like the ovaries. So you're looking to see if there's any tenderness in those areas too, just so if they have any like inflammation in that area, if there's any torsion, or if there's any free fluid, that could be signs of infection. And she was tender when I moved my finger towards the right side of her pelvis, meaning that her right adnexal was tender. So once you start seeing that, it could be possibly PID. It could be torsion, is very high on the list at that time. It could be a cyst that ruptured. Or it could also be an appendicitis, because your appendix is a retroperitoneal organ that, you know, it kind of, if you push down in the right lower quadrant, most of the time they tell you look out for signs of appendicitis, like a patient may have appendicitis. And her neuro exam was normal. So as I'm telling you guys this physical exam, I've kind of already started giving you what my differentials are and what I'm thinking about. And your physical exam also helps you lead to what you're thinking your patient have. In the emergency room, you don't do like when you write on paper, they tell you you do physical exam, then you do labs, then you figure out what differentials they that you're gonna work with. But in the ED, as soon as your patient's telling you their history, you immediately start thinking of what's going on and how you're gonna treat them. So you're treating and you're doing labs and you're testing all at the same time. So for this patient, my differential, my emergent things that can immediately kill her or at worst get her to, you know, become unstable very, very fast, where like ovarian estrogen, where she can lose one of her ovaries or like lose blood supply. Tubal ovarian abscess is 2A, meaning like she have like abscess in the by the ovaries and stuff. Ectopic pregnancy, if her pregnancy test was positive and there's no pregnancy in the uterus and it's somewhere in like a fallopian tube or some like outside of in the abdominal cavity, that can also cause her to be very tender in the right lower quadrant. And a ruptured appendicitis is another thing that can immediately cause her to go down really, really fast or possibly die, or that we have to now rush her quickly to the OR. Urgent things are like just unruptured, like blocked appendicitis, like appendix. PID is urgent because there are patients who can be febrile and be septic really quickly and get septic really quickly, and they're throwing up, they're unstable, their pressure is like all over the place. You want to quickly get to that. And non-urgent things that can cause right lower quadrant pain are like fibroids, muscle strain, non-obstructing kidney stones can also cause you to have right lower quadrant pain. So most of the time when patients come in, like this woman came in looking pretty normal. If you look at the history, right? Correct? Like apart from the 6 months pain and the pain that got worse in the last 3 days, there's nothing abnormal about her. She wasn't throwing up. She was not vomiting. She did not have any fever. She looked really well. Her exam was only positive for just like the right adnexal tenderness. So she wasn't someone that was hitting crazy unstable patient to me. So on a regular day or some days, like some providers would just check it as like, oh, just take Tylenol, ibuprofen, and then like follow up with your GYN doctor or whatever, which is something you should never do. Always take your patient's complaint very, very seriously. And if they're telling you they've had 6 months of chronic pain, but then now they decide to come in for something, know that this is important. This is something you do not want to ever just ignore. And her exam of the right adnexal tenderness was very, very telling as well. So once we got that part, I started thinking of what's most likely the issue here. Appendicitis was very high on my list. TOA, torsion. Ectopic was ruled out because her POC was negative. And pelvic inflammatory disease is another possibility. And then my least likely was like cystitis because she didn't have any urinary symptoms. Muscle strain was less likely. She was not telling me that she lifted or has been lifting weights or anything like that. Pyelonephritis was also like a little bit ruled out because she didn't have any fever. Even though her UA was also negative, it was like fine. And colitis, I thought of colitis because for someone that had been having like general 6 months abdominal pain, it could have something to do with that, but she wasn't having any diarrhea. And she wasn't like constipated. That might be like, oh, maybe like an IBS syndrome or something like that. And nephrolithiasis was also less like because her UA was also negative as well. I'm sorry, Stephanie, is there anything you want to add or do you want me to slow down?
Okay, so I wanted to ask, like, how often do you see ectopic pregnancies? Like, do they come often?
In my ED, I actually do see ectopic pregnancy very often. Pandemic, COVID has caused a lot of people to get pregnant. Okay, let me tell you, people are out here getting pregnant, and COVID, they were doing it. And unfortunately, once in a while, we do get ectopic pregnancies come through. And in the book, most of the time, they write it as pretty, like the people are pretty unstable. Sometimes they start having vaginal bleeding. They have really, really bad abdominal pain. They're like nauseous. Sometimes they're vomiting. They're sometimes febrile already. And once in a while, you get patients who it's just like mild abdominal cramping. And then they're like, oh, I tested positive. I just want to make sure everything's okay. and then they do an ultrasound and you find out IUP is not confirmed, their beta HCG is not as high as you would expect it to be at the weeks that they're telling you, or you can't find a fetal pole in where it should be. So then you get concerned and you now have to do like an explore I do not know how to pronounce that word, but like you go into the OR and then you look for where the pregnancy could be. Yeah, there you go. Tongue twister. So yeah, but yeah, I actually do see quite a lot of ectopic pregnancies. Unfortunately, it's always sad when I have to like, share the news, or when the patients are looking to me and they're like, "Oh my God, like I really want this baby," and you tell them that like you can't find an IUP, and then you don't know what to do. And then sometimes some patients will tell you, "I want to go home. I'm like, I want to come back for ultrasound or like an official ultrasound the next day," and you have to tell them the risk that they're taking with that, because God forbid, they start becoming septic, or like ruptures, or like something, like it can go left really, really quickly, and and at that time they have to sign an AMA, because now you're informing them of the risk of them going home. Do you have any other questions?
No, that's it. Thank you so much.
No problem. I know that I kind of went on a tangent over there.
Okay.
So, labs that you would order for mostly all patients that come in with like abdominal pain, you want to order a CBC, which you're looking for like a white count, benzemia. You want to look at the H&H. If they have any like vaginal bleeding, you're looking for like hemoglobin, hematocrit levels. If they don't like platelet, any anticoagulants, you want to look at the like platelets level. CMP is comprehensive metabolic panel, and you're looking for like electrolytes. You're looking for glucose. You're looking for their potassium, sodium levels, their BUN and creatinine, their kidney function level. We do CMPs all the time. Other EDs, some people will do BMP. It makes no sense. You're still going to need the liver functions anyway, so you might just send a CMP real quick so you can get all of that. For this woman, it was all normal. POC is just during pregnancy test. You just urine test. You just do it right there. It comes out. It came back negative for her. Shock panel for us, it was just it's like lactic acid, creatinine, BUN, creatinine really quickly. If you need to send a patient to the to CT scan, you want to know their kidney function is good, just in case they need an IV contrast, and also a couple of electrolytes like sodium, potassium, and all that things. Lipase, you're checking for if the patients have like vomiting, abdominal pain, or like they're a chronic alcohol user, looking for pancreas function, things like that. And then UA is urinalysis. Nitrites are what you're looking for if they complain of like burning or discomfort on urination. With UA, like what else is on there? Like white blood cell count, bacteria count. If it's a clean catch, most of the time, if your urine tastes like turbid, things like that, the patient possibly have a UTI already or something going on. And if there's like blood, a lot of blood in your urine, that will kind of point you toward things like nephrolithiasis, which is kidney stone, or if the patient is often on their menstrual cycle, they will have blood, obviously. And then GC is gonorrhea, chlamydia testing. I have a rule of thumb that when I'm doing pelvic exam on most women, I ask them immediately, can I do a GC chlamydia? Because I work in Brooklyn, I'm not stereotyping, but there is a high rate of STDs. And let me tell you, the last thing you want is to have them untreated. So most of the time, if I'm doing anything pelvic related or exam, or you come with abdominal pain, women, I always ask them to do a GC swab, even if they're in a committed relationship. And it doesn't come back immediately. It takes about a week for that exam in our facility to come back. And COVID PCR, if I have suspicion that I'll be admitting you, I will do a COVID immediately, just because that have a faster turnaround for how quick you can get upstairs for admission in our hospital. So for her, I put a stat label on it. It came back negative. And sometimes some patients will come in with like vague abdominal pain, nausea, vomiting, and they will have COVID, have any respiratory symptoms. So that's another thing to also look out for. And imaging studies that I did on her. So because of like my findings of right adnexal tenderness and the right lower quadrant abdominal pain are very pretty much normal labs as well as like vitals. I just went ahead and scanned her because 6 months of abdominal pain, I wasn't 100% sure. I was thinking she possibly have some form of gastritis, but then that is absolutely unrelated to the pain that she had 3 days ago that started worsening according to her. So it showed that she had dilated appendix with surrounding fat infiltration, which raised concern for acute appendicitis. So CT scan is your test of choice of imaging for appendicitis. In the ED, ultrasounds can sometimes pick it up, but a lot of people, most of the time, it's not what you really want to do. If she had like ovarian abscess or anything like PID, CT scan would have also picked that up as well. If she had any kidney stone, a non-con CT is better for stone studies. She'd have it, like it would have also picked it up with the one with the IV, but non-con, like non-contrast is what you really want to do for if you're looking for anything stone. She also had like an umbilical hernia, which I believe was possibly reason why she was having some of the abdominal pain that she's been having for the last 6 months that she never came in for. So then at this point, your management become very, very simple. You just consult surgery. We tell them like what's going on. They evaluate. Most of the time, surgery love this thing where they like don't want to come and do anything. They just push off the, oh no, the patient, if they're stable, whatever. No, you fight for your patient and tell them you need to have them managed and like evaluated immediately. Because they're like, oh, her vitals are stable. They don't think it's really nothing. But I'm like, no, look at the image. And I forgot to include the image of the actual CT scan. It was kind of hard to kind of record it and attach it to this PowerPoint. But she had like her appendix was like very, very retroperitoneal. So it was towards the back. And if you wasn't really paying attention, if you didn't really have a really good eye, you would have never caught it. And I actually didn't catch it at first. I actually read it as a normal CT scan initially, but then my attendant was like, no, let's look at it over. And then she went over it again and she saw it. And then the radiologist also called and told us that, oh, okay, like she does have like an acute appendicitis, which is why I consulted surgery. And then that same night she went for a lap appendectomy, which is just to remove the appendix. And I was in the ED, most of the time, you never get to really follow up your patients or know what happened. But if you remember their names or like you just want to look them up in the system, you can quickly do that. The next day that I worked, I like looked her up and she had a successful surgery and she was discharged a day or two, like the next day after the surgery. And I was actually happy because she initially didn't want to stay. She was like, oh, no, I don't want to stay for the surgery. I'm scared. And I had to like convince her and tell her that if she goes home and have a rupture or anything happen or she becomes septic or anything like that, like those are chances she does not want to take. So just a quick thing on appendicitis. Most commonly, you'll find patients coming with nausea or vomiting. They cannot keep anything down. They can't eat. They have fever. But not all patients will come in with not all patients will come in with 1 or 2 days of like abdominal pain. 9 out of 10 times it will be right lower quadrant pain. But sometimes you will get patients with like diffuse abdominal pain in the very early stages of appendicitis in the ED. And then when it becomes like really, really worse, then it will localize more to the right lower quadrant. As I was saying about special tests, positive psoas and obturator signs are some of the special tests. If you look on YouTube on how to do them, it shows you what type of tests they are. And then you will most likely on most patients find white blood count. She didn't have any white blood cell count. So I understood why surgery was a little hesitant to take her to the OR, but she really, really, really tender in the right lower quadrant. I think because she had a really high pain tolerance and stuff and how retroperitoneal her appendix was probably why she wasn't really feeling the as like acute as she probably would have. And you will see bandemia, which just means that like a lot of like new early white blood cell counts. And you do a CT to confirm, and then you do a lap appy, like I said before. So just a takeaway point, you know, patients will not always present as textbook cases. This patient did not present as one. She came with like abdominal pain for quote unquote 6 months, got worse in the last 3 days. She did have the right lower quadrant pain, but she didn't have any nausea, no vomiting, no fever. She didn't have any white cell count. The only thing was like the CT scan was helpful to confirm our diagnosis. You have to advocate for your patient at all times. When you work in ED or any specialty, when you have to like consult other specialties, you have to constantly have to fight and be like, no, my patients need this. This is why they need to have this done. And if you don't agree, I need you to document this and why you're refusing. And make sure that you do your part at all times to take care of your patient. And patients will sometimes tell you too much or too little in the ED. I've had patients who had history of ESRD, stents, things like that, and they will downplay their medical history. Or I'll have patients that have nothing related to what they came in for, and they tell me long stories, elaborate stories that's not related to why they came in. You have to kind of keep them on a path and guide them at all times. So learning how to do your HPI, how to ask questions is the beauty of medicine. Is one of the things I'm still learning 1 year into my career. I'm still learning how to ask questions, how to be more focused, how to be more direct, and also not to be narrow-minded when I'm asking my questions either, because I've had patients come in for something. I'm like, oh, I totally know what this is. And then I don't ask more questions. And then I come back and I find out that, oh, no, this is what happened. So you always want to be very focused and give your patients time to tell you, but then you also don't want them giving you way too much story either. And then you learn to improve your techniques with each patient, learning how to do an exam, pelvic exam, learning different things to, your physical exam is very, very important and helps you guide how and knowing what's going on with your patient. So those type of things are things that I would say throughout my 1 year as a PA in the ED, I've been working on, I've been trying to get better at, and I think every day I'm learning and I'm progressing, and I hope to continue to just keep learning every day. That's it.
This was amazing. God richly bless you, because this blessed me. I'm also located in New York too.
Oh, great.
Yes, I attend Pace University.
Ooh, I applied to PACE. Those people rejected me.
Oh my God. These people, man.
They reject. I remember applying, and I was like, I want to go to PACE because it's like in New York, and then they were like, we don't want you.
Yeah, they're very strict on their stuff, So,
yeah.
But thank you so much. This is really good.
Do anyone have any question? I hope I didn't go too fast. I hope I stuck to the point.
Thank you so much, Vicky. That was amazing. You were so thorough. Thank you so much, and you're an awesome teacher. Thank you for that.
Thank you.
Thank you.
I'm gonna stop.
Thank you. Someone asked about the 6 months of pain and about possible rupture after 6 months. I was gonna say that I feel like of course that patient was in textbook, but I feel like saying patients that come in with like chronic pain like that, it kind of throws you off, and I feel like that's a which I forgot the name for that, but that's kind of just to kind of throw you off. But she's had this pain for 6 months, and like you said, it could have been more of the related to the umbilical hernia. That I think was, but then having it worse in the past 3 days, I think that's when the appendicitis is more like starting to come on. So when patients come on with like acute on chronic pain, that's, I think you should hone in on that acute condition that could possibly be going on. Like her saying that, oh, I've had it 6 months, but it worsened the past 3 days. The past 3 days is like, okay, why is it just all of a sudden now bad for you to come in? So yeah,
I agree. I totally agree with you. So I cheated. As I said, I looked her up. Actually, I actually looked her up again yesterday before when I worked last night, and because I was still working and trying to make this perfect, and I saw that she went to a GI doctor because that was some of her referral for the chronic pain that she was having, and they found that she was positive for H. pylori, and she does have So I think that more to do with her chronic pain, and she just never followed up or went to the ED. But I think when she started a 3-day pain, when that 3 days was the acute onset of the appendicitis, and she just chucked it all up as the same thing that just got worse.
Exactly.
Unrelated.
Exactly.
And trying to ask questions, as you said, trying to pinpoint okay, what changed? Why are you here? And most of the time, that's what you will find in the ED. It's patients who have had this chronic issues, and then they come in, and then you're like, okay, so why are you here? What makes today's pain different, or what today's headache?
Yeah.
So you did a person headache, and let me tell you, I was like, yes, you get those like, okay, this is different. This is something I've never had before, and you now work them up and find out what's going on.
Yes, exactly. Yeah, Stephanie had a question.
Okay, so oh dang it, I literally forgot. But I think overall this was very good. I learned a lot about like, even like the flow of like, ruling out certain things to get to your main point. And obviously I think that, as a medical health provider, I think like your listening skills and able to connect, like as you said, like asking questions so you can get like it can make your job easier when you ask questions, So that really helps me because I love to ask questions. Everybody tells me like, oh, Stephanie, you love questions.
Trust me, I ask questions a lot, and I work with. Not like my attendants, the people I work with, like I'm amazed. Like I really enjoy a lot of my coworkers. Like I just ask them questions. As a new grad, this is you're a new baby. You're learning how to walk. You're learning how to talk. You're learning how to dance. You're crawling and you learn and you want to absorb as much. And if you don't ask questions now or you stay tight-lipped, no one's going to help you. No one's going to know you need help. And you're just going to sit there stewing in your own, like, oh, I don't know this. Like, it's not every question I speak, like I ask and say out loud. Like I will check on UpToDate myself, or like I'll quickly look up something myself. But sometimes just get a verbal answer from someone, and they will give you with an example. Like they'll tell you, oh, I've had a patient that like I had an EKG that was like Brugada sign, and I was like, oh, I've never seen that. And then they tell you a story, and then that sticks with you, and then you never forget it. So, and I'm an auditory person. I love to hear. I love to listen. I do and hear. Those are like my top two learning things that I know how to do. So if I'm doing something, I can retain it, and if I'm hearing it, I retain it even better.
Wow. Okay. I'm currently looking for like healthcare experience, and I'm so interested in the emergency room. I almost had a shot at a per diem medical scribe at an emergency room, but I didn't get it. So that was so broken. But
keep trying, honey.
Yeah, I will. I would definitely email you and connect with you after this. So yes, definitely.
By the way, if anyone wants like this PowerPoint, or I don't know if the recording stays, like I can always send it to anybody. If you guys want it, just hit me up on like my email or anything, and I'll be happy to send it.
Thank you so much. You are amazing. Thank you so much.
I'm happy.
Thank you, Stephanie. Are you applying this cycle, or are you you're looking for an MA job right now?
Yeah, I'm applying next cycle. Yeah, next cycle. Basically, everything that she did, like applying her senior year.
Okay, nice. Yeah. Well, good luck. Thank you so much for coming on. You did awesome.
Thank you. Bye.
Thank you. Bye. Thank you so much, Bookie. Thank you. This was amazing.
I'm happy to be here. Thank you for having me. Thank you for extending the invitation. You're doing such a great. I was just telling somebody hit me up on Instagram the other day, like 2 weeks ago, and they were asking about like shadowing. I was like, I really wish I could like help and have students shadow, but because I work in like a state hospital, they're not taking like students for shadowing or anything like that right now. So I was like sending out your link for e-shadowing to them. Funny enough, before you hit me up on IG, and then I was like, keep. And she hosts e-shadowing all the time. And then you reached out to me, and I was like, oh my God.
Thank you so much. Yeah, you seem great. I love your content. Thank you so much.
Thank you. If there's any questions, that I don't know how, do we have like, is it time? Is the time over now?
Oh, it's about an hour long. I mean, we started a little late, so it's fine. But usually I end it around this time. But I don't know if there were some questions, but either way, I put your contact information. It's Bookie's blog. I'll put it again. Her IG and email are basically the same. So if you guys want to reach out to her, and I'm sure all of you know my contact information by now. This is her IG, Bookie's blog, and then her email is the same, bookiesblog@gmail.com. If you guys want to reach out to her, I'm sorry we probably didn't answer all of your questions. Well, I know we didn't. I'm sorry if we didn't answer or get to all of your questions. If you have more questions for Bookie, just feel free to email her or DM her. And same thing with myself. Just give me some time to respond to the emails. So thank you guys so much. Thank you for coming on.
Anytime, honey.
That was a great.
Are you in New York, probably?
Yeah, I'm in New York right now. I'm working right now, and I'm in Brooklyn.
Girl, we got to link up.
I know.
Have a time.
I know. I'm just never off. I need to email you, or DM you, but I'm just never really off. I'm like.
Just me. I have to make up. I have like dates and like friendship meetings and everything all the way in May and June. That's how busy I am.
No, I'm gonna definitely coordinate my schedule better for May to try to get more days off. Because when I get like a week off or so, I just go out of town. But I need some days off in New York to actually like do New York stuff and hang out.
I agree.
Thank you so much. Right. Thank you guys. But I'll DM you, Vicky. Thank you so much.
Anytime. Bye, everyone.
Bye, guys. Thank you, Stephanie.